So it is week 9. We are now going in the downhill climb. Week 2, it's gonna exam 3 is gonna be next week, and the reviews are going on this week. Just like was said earlier, the review this morning was canceled and put till Thursday. So it comes to this: tomorrow, Wednesday, 10:30 a.m. Thursday, you're going to have it at 3:30 and at 8 p.m. Different professors. Then you're going to have Friday at 12:30 and me Friday at 3 p.m. On Saturday morning at 10 a.m. is going to be Professor Morris. So again, as soon as I get these, they'll be thrown up. You'll be having those reviews and you'll have the information. I'm also going to be compiling all the HESI stuff you need, getting it out early. It will not hurt you to start studying because stuff from the exams is on there too. So it's things that you can look at. You have all the weekly Kahoots that I've sent. If you have not gotten them, let me know. I can always send them, even if you're not in my class. I will send that to you. And you'll have 2 Kahoots that are 100 questions, and you will have 1 recording, which is a good questions and answers. Now, anybody who wants that information, send me a message on Canvas so I get it. And from there, I click off as I go and make sure everybody gets, okay? Somebody just asked for it. So this week, there's no quiz. That's the first good news that we have today. And we know that discussion question 6 and then the dosage calculation and it is worth 1%, so it is worth something. Now, if you are going by the book, it's 8th edition. You're going to be doing the end of chapter 24, questions 1 through 40. If you by chance just have that edition, the 7th edition, what's in Canvas is the worksheet for 7th edition. I posted that 8th edition worksheet to work on in my announcement. Again, if any of you didn't get it for any reason, let me know and I'll send it to you. All it does is just 1 through 40 gives you the exact page it's on, but it is the end of chapter 24. It's the pediatric, it's the end test, questions 1 through 40, okay? But if you want that paper, not a problem, and you can work from there. Now, all your answers are in that book, and you can copy and paste all you like. But remember, you might see some questions of this. I mean, a lot of you have been getting my calculations stuff, have looked at it, listened to reviews, met with me, many of you in here. So it is a great review to look at. And I know some of it is complicated, but it will help you in the long run. So here we go. Next week is going to be exam 3, as I said. After the exam, we're not going to do any class after. Tell you why. Next Wednesday, I'll be on a plane. I'm going to Mexico. My daughter's getting married. And I'll be leaving early in the morning. I'm going to almost turn off my phone. And I never do that. But my promise to you is I give you everything you need to be successful before I leave. And I will be back the following Wednesday, the 20th, is I'm back in town. I start work on the 21st. But I will be reachable. And I know Professor Morris is going to be covering me. So any questions? And of course, Dr. Brown. Dr. Brown's very aware of what's going on. And you know, she's always there and always is extremely helpful. As I always say, I encourage you, go to her. If you need something, can't get a hold of me, please. It doesn't look bad upon me at all, okay? So here we go. Let's start with this week's, and it's neuromuscular and musculoskeletal. It is 2 different, but very much connected systems. I'm going to give you some of the things you need to know about it. So here we go. I like pictures, and my PowerPoints every quarter gets more and more pictures because I think pictures really tell you a lot about conditions or children's feelings, expressions. So I make PowerPoints and I make them colorful. Now, from those of you who are not in my class, if there is any point you're not understanding or you have another question about it or a comment, stop me. I do not mind to be stopped and ask a question, okay? I don't get upset. I don't get frustrated. I think if you don't know, probably somebody doesn't know also. So the immobilized child, you can see whether it's a child or adult, there can be all different things and reasons why they're going to be immobile. Now, there are some children with congenital defects where they're never able to walk or they're never able to even move the way that they should. We're going to go into some of those. Some are degenerative. Then we get those infections, injuries, car accidents, crush injuries, etc. Those create that immobilized child. And we know that there's all sorts of things that we can do. Now, immobilization, we always think heart, lung, muscles, bones, right? We need to keep the body moving, range of motion, PT. We need cough, deep breathe, lung exercises, prevention of all of the clots, the thrombus, and all of those things affect children. Now, children can go a long period of time immobilized for many different things, and they're apt to get many conditions that adults do. Decubitus ulcers, foot drop, children can get them. So don't just think because they're little, their skin's better. It's actually more sensitive. So just remember those things. Now, a kid. Now, let's say they are awake and alert or semi-awake and alert, you know that they're going to be affected. They're in a hospital. It could be in the ICU. It could be with all the noises, the dings and the dangs and the alarms and emergencies and whatnot going on. Or it could be they're in a room. The door is closed. Maybe you're on some sort of airborne isolation. So now you've got a child who is there. They not involved with people. They're not in the school. They're not with their friends, their family. So they become feelings like they're frustrated, helpless, and now they're everything that goes on, they're getting anxious about. And sometimes they can actually become aggressive and angry. So we know that children, separation, anxiety, it's that regression. Older kids can do it too, when they're really upset. Now, a kid who's has to be in a hospital a long period of time, you're going to say that family is the unit will be absolutely disrupted. The parents, they have to work. Many have other children, or they have mothers, fathers, something else that they need to worry about. So, worrying about that child is that full time thing, and it can disrupt it. So, remember the parents in this. It's not just the kid who gets upset with issues, parents do too. Now, traumatic injuries, kids are always running around bumping, falling, and doing crazy things. They think they're Houdini. They think they can do whatever they want, and they do get hurt. Now, a contusion. Now, a contusion is a bruise, a simple ecchymotic area, right? Well, remember that is a release of blood and underneath the skin into the tissue. Remember, it can press on blood vessels. It can press on nerves, decreasing or increasing pain. So always remember when we're looking at a contusion, not only just look at the area, look for your neurovascular signs. Distal pulses. Is blood still getting down there? What's capillary refills? Very important concept. Now, dislocation. I've seen many types of dislocations. I've seen the shoulder. I saw an ankle dislocated. I think that was probably one of the hardest ones that I had to work with to put it back in because they were yanking on this. It was a young teenager, young leg, pulling it and trying to put it back in. And the child had quite a bit of sedation on him, but was still quite awake. So dislocations can be hard to watch, but you can see it pop and you see an instant relief of pain there. Now, Down's children, you think of them. These are the most flexible children person ever. They can put both legs up over their shoulders, but their tendons and ligaments are so soft that it could pop the hip. And then you might have some issues with blood circulation, and that would be a problem there. Sprains, anybody who's ever played sports has had a sprained ankle. Absolutely. I know through high school and college, I played every sport there was, especially volleyball. Come up, slam it, go down, and guess what? Right on my ankle. And then you have this big, swollen, very painful ankle. And you can actually, when it's done, you hear it crip and crack as you come down, landing on it. So it is a rapid onset of swelling. I'm going to show you how to take care of that. Now, strain is when you use one thing over and over again. This could be runners who just run, 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 run. They're using those muscles over again, and it becomes very painful. Gymnasts, that's what happens to them also. So we get an injury, break, sprain, something happens, swelling's going on. Initially, what do? Well, when I played volleyball and I come down and I would hear my ankle go, the first thing I do is put my foot right up in the air because it's extremely fast how it swells. So rest, stop, ice it, put a compression elastic bandage on it, and elevate it. As a longer term treatment, they are putting on splints or casts. Today they're putting on casts more than they ever did. They feel that it does support the leg, the muscles, the tendons, and it puts it in the correct position, and it actually aids in healing. Fractures. What do kids do when they fall down? Hands come out, right? They catch themselves. So where are the biggest breaks? Wrists, radial, ulnars, and bilateral. I've actually seen many times. Those little hoverboards, they fall down. What do? When they came out that first Christmas, we had two of them, bilateral, fractured radial ulnars. So they're coming out of Christmas break to school with casts on. So just be careful with fractures that we question, parents and the child alone if we can. Infants should not have fractures. Their bones are not that. They're sort of softer. They sort of bend. They're malleable more, and they don't crack. They don't ossify like the older ones. So you see a fracture in an infant, it needs to be investigated, and it could be child abuse. And I've seen child abuse, and you wouldn't suspect it, and it is like that. Now, types of fractures. There is the one that we think about, broken arms is simple or closed. Bone does not come out. Now, I gave you the example of the open here, so you can see that one needs to be fixed and it needs IV antibiotics. That means the outside environment, dirt, wherever that break and that laceration occurred, now that all that contaminants going inside there. So that it requires IV antibiotics. And usually the cast, they put a little window there so you can still treat that laceration. You have the complicated ones. These can be like the rib fractures, which goes through a lung. That would be considered a complicated. And a comminuted one is a small fragment and it's broken, and it's all of those little pieces in there are really creating havoc and a lot of pain. Now, children are different from adults because they're still growing. And they grow in their bones in what we call the epiphyseal plate. It's also called a growth plate. It's at the end of the bone, usually, at the end of these bones in here, right? So you get a kid fell down on the elbow and you see a growth plate fracture. This child will go to the OR. They will do an open reduction internal fixation to make sure the pieces of bone are exactly where they want them to be. Or the arm can be crooked or not grow like the other one, whether it's an arm, a leg, or anything. Growth plate fractures are the ones that we really pay the closest attention to, because we don't want that child to have that shorter or different shaped extremity. Now, one thing about kids, they heal quick. Look how quick one of these an infant first 28 days of life, look how quick a bone will heal. You remember some infants are born and there's fractured clavicles because of, vaginal delivery, right? That can happen. So 2 to 3 weeks is healed. That's really quick. Now, me and you, it's going to be 3, 4 months with cast at least. But look at the young children. It's right around 1 to 2 months. Usually 4 weeks they're taken off. So understanding that the younger the child, the quicker it heals, those children really need to have it fixed and put in position pretty quick, don't they? So usually they come in because they're complaining of pain and they're swelling. Um, and they come in and we're going to do an x-ray and we're going to see, well, that one on top, you just see a crack. That might just need just good positioning and a cast on for a month and the kid will do well. Now, one of the things with the legs, if you see a kid not wanting to put their foot down on the ground, that usually is a fracture. Now, if a kid will put their foot on the ground, it's probably more of the sprain. Okay, even animals are like that. They don't put their leg down because it does disrupt it and it does cause more pain that way. And what is our goal? Well, we want to reduce it, immobilize it, and make sure that the function and deformity, there's no deformity, right? We want that whatever bone to do what it's supposed to do. Now, what are we going to do? We assess fractures and then we send them home with a cast. So parents need to be evaluating these things at home. And it's all the P's. So pain, where does it hurt? Is it getting worse? Pallor, the circulation, are the fingers turning pale? Pulselessness, if you can feel a pulse and it's not there, again, that's an emergency. Paresthesia, all of a sudden the fingertips, the toes, they're getting really numb. Having parents or the kids touching them like, ooh, I don't really feel that well. Something's happening. And of course, if they can't move it, and then compartmental syndrome gets to the point where it gets a lot of pressure in there. Now, I've given you a picture of the most absurd thing that can happen, but that would be something where a cast or something was on there, somebody didn't check it, and they're going to lose the arm, right? So it can get that bad. So making sure parents know the 6 P's, very important concept, 6 P's. So when we send them home, we need to tell them how to, take care of the cast. They can't get it wet. They have to still shower. So we give them little bags to put on, take care of it. We tell them, of course, we've done already, a discussion question, nothing inside, a cool hair dryer sometimes helps with it, but put nothing down in there and don't take the hanger because it itches. And I understand it does it. I've been blessed. I had one fractured toe a couple of years ago, and I never had anything before that. But I can understand that toe really hurt when it cracked. And it was a nice across it was my big toe. Now, even with, these casts, again, no powder in there. Now, sometimes you have a fracture of like a long bone. It could be, usually when we think of fracture and traction, we think of a fractured femur. Now, this picture down there is what we call Buck's traction. And fractured femur has 2 edges, and the edges have cracks and sharp edges, and the thigh muscle pulls it in. So those little cracked edges are really getting into the muscle and creating pain, right? Sharp edges, nerves. So any little movement, cough, a deep breath can create pain. So, and we do this right in the emergency room. Children come in, fractured femur. We'll get them a regular hospital bed, put the fraction on, the traction, the Buck's traction, and we pull their leg so that the ends of the bone are together. Now, that's not the treatment. We're going to be putting a rod down the middle of the femur the next day or two, but at least we've decreased the pain there. So it helps with the pain, and it keeps that bones together so it starts being where it should be. Now, there's other sort of traction, skeletal traction. Oh, usually you think of this for your neck. Um, Again, what does this do? It keeps you straight. I had a little 16-year-old boy come in by trauma rescue, and I was the primary nurse on call that day. And we get a call that he slid into third base, his head hit the defender's knee, and they heard a crack. He had already had right side paresthesia, and the left side, he was also getting numb. So definite injury was going on there. So what we did was um, he came in 16 years old. I actually got him through an MRI. I took charge, kept that neck straight, and we got him up to the pediatric intensive care unit. And neurosurgery came in and put tongs in and put them on ice. And what that did, it kept that fracture as straight as it could. I'm telling you, this child had a fracture that looked like a little triangle. It was what we call an angulated C5, C6 fracture. This kid could have been paralyzed from the nipple line down. I mean, this kid could have had really bad paraplegia. He didn't. I went to see him 2 weeks later upstairs in the room, and he had slight little tingling on the right foot, but barely anything. He was going into rehab just to get strength, and a year later, he came and hugged me in the ER, and he was perfect, jumping around and, things like that you never forget. So, making sure take control of that, whatever that neck injury is, the back injury, making sure that you don't make more of an injury. So traction, it helps with the pain, it keeps you aligned, and there's all different types. There's skin traction, and there are the skeletal traction. Those tongs, like this little girl here, that is skeletal. It's little pins goes into the head. You need to do pin care on them, look for infection. Also the cervical one, the same thing. The Bryant, the Bucks, the Russell, these are things that we use for hip dysplasia and we use for fractured femurs. And, which one do they use? Well, Brian's traction, the kid can't be too big because it won't pull it up correctly. I believe it is 25 pounds, I believe is the number, how big, but you don't have to know that. I'm just saying it to be tiny. And then we can use Russells and Bucks. We use them on fractured hips on the elderly too, don't we? So another thing we have is what we call a external fixation device. And I got some really good pictures here for you. And what they use that for is really a macerated bone, or I've seen it used where you have a child born with an arm or a leg, one shorter than the other. They can break the bone, open it up, and the bone will heal, and it can gain length on that bone. So they'll have equal sides of whether legs or of arms. So I think that's pretty neat because new bone is formed there. Again, with this, it's all about skin care, all about that pin care. Now, children can be born without an arm, lower arm, all of their arm, lower leg. There also, I met a little girl who was born without a tibula. She had a fibula, but no tibula. So they had to do a below the knee amputation. There was no bone to put there. The kid had nothing to stand on. And that required that this child is an amputee. Now, children are so resilient. The ones that were born without it don't understand what the difference is if they had it. They just know they're different. This little girl actually was a friend of mine's daughter. I met, when she was 5, I believe, when I finally saw her. And this little girl took her prosthesis off and was running around the house chasing my kids with it, gonna beat them up with it. And she was without a prosthesis, faster, running around the house. And I laughed so hard. And my kids were at the time 9 and 11, she was 5, and they were having the best time. and she was winning. Remember, with amputees, it's after surgery. It's all about phantom pain, and it's really hard to work with. Yeah, my toe hurts when you don't have one, right? Children, they love competition. We know that many times children need to get out, they need to warm up, they need to have proper equipment, and they need to do whatever they want to do, and they want to win. So they push themselves like crazy. So we know there's going to be injuries there for whatever reason. Those overuse injuries are, as I said, doing the same thing repeated, 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 and they little fractures and stuff on them. So again, it requires rest. Now, if you have a child, you go to the pediatrician. One of the first thing they do is take the hips and push them in and out, right? And they see if they're hearing any clicking or if their movement's good. They're also looking to see their butt cheeks, their gluteal folds, are they equal? Because developmental hip dysplasia, it would be shorter on one side. And I want to explain why. You've got the hip joint and you've got the femur, the head of the femur here, right? Well, instead of being born in the socket, it's born up here, usually here all the way up. Okay. So what happens to the leg? It gets shorter. And that usually is that key that will tell you about it. Now, just like I said, these are things that you see. You see a short limb, you see abduction. Remember that word, abduction on the hip. You see those gluteal folds going to be crooked. They're not going to be equal. And you see positive Ortolani and positive Barlow test. You hear that clicking going on. How do we take care of it? Well, we're going to put them in just a simple little harness, it's called. It's a Pavlik harness. Remember what I said about bones and infants, right? They heal quick. So we put them in this abduction where their knees are up like a frog, right? Their knees are up, and it pushes those femur balls of their femur, the heads of the femur, back into where it should go. Usually this works. It should be on 23 hours a day, and you should wear a t-shirt underneath to prevent that skin rub down, that rubbing of the harness there, because these kids are still going to move, right? And we basically take it off for bath time and for changing them every day. That's usually what we do. If they're a little bit older and they're resistant to it, sometimes they get that spica cast, which is from the knees to their chest, right? Which can happen. And then older kids, those tendons now are tight. They've got to cut them. They got to open them so that they can float those bones back to where it should be. Club feet. Now, there's many different names of club feet. And you could look at all the names, but you don't have to know all the names. Thank goodness, right? All it is the foot and the ankle, there's a problem with them. And what they usually do with them is every week, remember, they heal quick. Every week they get the cast changed. And it will eventually take that foot from being down and out, and it puts it back to where it should be. Now, once this is done, they're usually good. These children must be followed up by orthopedics, making sure that their feet are good, and they'll make sure that they don't need special shoes or anything, and making sure that those ankles, those feet are in the correct position. Those cast method is called Ponseti, and again, the kids that get older, they need good follow-up. Now, osteogenesis imperfecta, it's a really strange disease, and it's not curable. And what it is the other word is called brittle bone disease. You can just touch their ribs and they could break. I mean, you could try to start an IV and you could break a bone just trying to hold the skin back to get it in. They're very difficult to handle and manage. I used to just put them on a blanket. Somebody would hold one side and someone hold the other so I could change the blankets underneath, right? because they are so brittle. And even when they are changing the diaper, have somebody help you. They're very, very brittle. These children, they get this IV biphosphonate therapy and calcium and all these whatnots, but it really doesn't do much for it. What they try to do is to make sure they stay as they're breaking bones and they could, heal in very weird positions, that we put them in a position where they can be mobile. I know at the children's hospital I worked at in the days, you would see some of these kids in these electric wheelchairs going down the hallway, going beep, 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 getting to go into the cafeteria to go get something to eat or something. They're alert, but their bodies don't work with them, okay? So the goal is to keep them functioning. Leg calf Perth. This is an aseptic necrosis of the femoral head. It means it's not an infection. It just means the head of the femur starts to have necrosis to it. And usually what you see is children start to limp and they're in pain. And it is some reason why there's this decreased circulation there. So when these, get these kids with this pain, and you can see some's in the morning, so of course they're going to test them for rheumatoid arthritis too, right? Because that looks like it. But they do the X-ray of the hips, and they'll find this hazy covering on the end of the femur bone. And what they'll do is put these children on some NSAIDs for pain, anti-inflammatory. Sometimes that bucks traction, helps pull it, and just keeps it in line and keeps the pain from going on. And remember, these kids need some sort of care for homeschool, so it is quite it could take a little bit, a month or more, for these children to turn around, and usually they do fine. Now sometimes they need to go into surgery, but usually it will be fixed by itself with rest, NSAIDs, and that traction. Now, I'm going to do 3 spine sort of different abnormalities. Kyphosis is that humpback when you're bent over. You don't stand up straight. Kyphosis, humpback. Lordosis is the lumbar spine curves in. So you're sort of leaning backwards. So instead of the spine coming down, the slight, it's a very big indentation there. It could be born congenital, but usually we'll see this more during the adolescent growth spurt and children who are heavier. Now, scoliosis. This is the one that NCLEX loves to pick on. Scoliosis, S-shaped curvature of the spine. Usually, again, this is something that you could be born with, minor, but when they're growing, it gets more and more pronounced. Now, one of the thing about scoliosis, if you look at that spine turning, what it does, it impedes on one of the lungs. So if it gets more than 45, 50%, they have to do surgery to fix this, okay? So they're not going to do surgery under it. So what they do is they put these braces on, and they'll take and they'll put it, again, a shirt underneath, just like the babies, right, with their Pavlik harness, and put on this brace. And then it's physical therapy for exercising, strengthening those back muscles. All right. And usually it will get straight again. My daughter's best friend had this as a teenager, and she's nice and straight now. Now, Harrington rods, they're not doing as much of these anymore, but this is still in the book, still used. This is what we use for those curves that are greater, as I said, 40%, because they're now impeding upon one of the spaces for the lungs, and that lung needs to expand to breathe. Osteomyelitis, infection of the bone. what do you see? Well, a lot of kids like to step on stuff. They run around with bare feet, right? So feet get a lot of this. Could be the big toe. And all of a sudden it's going to get red and then it's going to swell and then it's going to get painful. And then it goes into the blood system, becomes systemic. Then you have a fever and now you're going to see elevated white counts in your blood count. And this is serious. This is the environment again went into the body. And we usually treat these with one of the medicines, the aminoglycosides for staph. So vancomycin. Well, what do we know about vancomycin? It's one of those aminoglycosides. We have to worry about peak and troughs and levels and fluid and ear, right? Ototoxicity, hearing loss, kidney failure. So we're watching them urinating. We're monitoring lab values. We're making sure they're hearing. We're making sure their values are where they need to be therapeutic. So it requires a lot of attention, and usually it's the parents that are making sure this stuff is done. And they do IV antibiotics. I know there is some new research thinking they could give oral for more time. But as of right now, I know that they're giving IV antibiotics. Now, high protein meals should be given for these children because, they need it for their bones. Again, they're going to be somehow walled off, isolated from other children, whether they're homeschooled and they're not in school with, the IV, etc., depending on the schools if they'll accept them. Now, here's a cancer, which is of bones. It's the femur, the tibia, the ulnar, the radius, but what could be the scapula? It could be the jaw, where they get these big tumors. And again, they have to surgically remove them if they can. They do that radiation, chemo, and then they try. Problem usually is, though, many times when we see it, it's already metastasized. Now, you've heard me talk JIA already, right? Rheumatoid arthritis. Well, in pediatrics, it's now called JIA, juvenile idiopathic arthritis. It's the same thing. It's an immune problem. It's an immune problem where your body says, I like you joints, I'm going to eat you up. And it starts going after the joints and inflame them. And when it does that, it creates a lot of pain. Kids are young when they're diagnosed. You heard me say sometimes it's a limp. Sometimes that's all there it is. It could make my knee hurts or my hip hurts. And they limp and they go and they'll be looking for JIA. What do you see? Well, you're going to see a lot of that morning stiffness. When you don't move a joint for a long while, it gets stiff. And I know this. In the morning, I've got to stand up and stand there for a second and stretch a little bit, try to move. And after I get moving, I'm better. So it does decrease during the day. It's hard to walk sometimes. They have to place their feet properly. Sometimes they're limp, knee hurts, ankle hurts. Again, joint swelling, disfigurements. I mean, sometimes the hands get quite bad or feet. We know what that looks like. And then there's something called uveitis, and that's the red of the eye. And this needs to be monitored by an eye doctor at least once a year to make sure. Now, the problem with JIA is hard to diagnose. It took me 8 years for them to diagnose me. Oh, I'm fibromyalgia, and that's all it is. I'm like, no, there's something else. I think I went to 5 rheumatologists. And that's not uncommon for this condition. You'll see elevated SED rates. You'll see all the inflammatory factors elevated. Your SED rate and your white cells can go up, and you can see what we call a C-reactive protein, and they'll be elevated. And then they will see ANA positive. You will see RA factor. And there's something else called a CCCP. They're putting more tests out. It's getting a little better. But again, it's very difficult to diagnose. So what do we treat it with? Well, moving, exercise is number one, keep them moving. And for pain, it's NSAIDs. The NSAIDs, again, anti-inflammatory. And then for those flares, they give corticosteroids. And now you've set up a routine, it's a JIA. They'll be placing this child on methotrexate and some sort of biologic, Humira, Enbrel, or an infusion of some sort. But the goal is to keep them up, moving, keep them pain-free. I mean, I'm in the pool as much as I can, and that's the best thing for me because I'm a fish. So for me, it's like good movement, and I don't even realize I'm exercising, which is the best way, huh? They say use of heat. Well, some people like me don't like heat. They might like cold. Heat makes me more pain. So again, asking the child or telling the child, this don't work, try this. And again, supporting that kid because he hurts, doesn't understand it, and of course the parents. Now, the other side of the board is the immune that attacks organs, any organ, right? Doesn't matter. We know that it's a lot of girls, and we know it's right at that pre-adolescent growth spurt, menses, getting their period, puberty, right? That's when we see a lot of it. And usually we start to see maybe those little rashes. I've showed you two different types of little rashes. Here's a little red rash, or you might see a rash like this. They're all different, but you'll see that butterfly, it's called. These children, before their diagnosis, sometimes they'll just start with this generalized pain in their joints and nausea, vomiting. And if it continues, they will do seizures. So it can be quite dangerous if it's allowed to continue. And again, you could do your lungs, pleurisy, pericarditis, your heart, right? Proteinuria, failure, the kidneys. So it's attacking organs. The goal of the treatment again with this is just to try to keep the body from attacking itself and making sure that these children are following their medication and they're doing what they're supposed to do, keeping them active. And these children are specifically very susceptible to sunlight. So making sure, I live in South Florida, making sure sunscreens and minimizing the amount of sun coming out. So Kristen is a 10-year-old, sustained a fracture in the epiphyseal plate of her right fibula when she fell out of a tree. When discussing this injury with her parents, the nurse should consider what? What is an epiphyseal plate?
It's where the fusion happens, no?
The bone growth. So
B.
bone growth can be affected by this. So very important that we know that and that we make sure that even the parents know, and the child, of course, that it's in a place where we have to make sure we get it straight so there's no problems. So neuromuscular or muscular dysfunction, cerebral palsy, right? That's muscular for sure. It is all about, it's a permanent disorder and development of movements and postures that they are not controlling. They can't control their arms. They sometimes they just shake and spasms, their muscles get tight. This is just part of cerebral palsy. It is the most common permanent physical disability. They
Professor?
could be born with it. Yes, good.
Jonathan says hello, by the way.
Oh, I love my Jonathan. Jonathan is a little, is he 7 now? 8?
He's 8, yeah.
Oh boy, 8 years old. He's this little boy in the daycare, this PPAC. And me and him just hit it off. He's nonverbal. He doesn't speak. But that kid would see me across the room and he would smile so big, and you see these big white teeth, and then he'd get so spastic waiting for me to come give him a hug and kiss him. And I will always remember him.
When you were with him?
Excuse me?
Did he have the tablet when you were with him?
Yes. He can talk to me. It's amazing. I love it. Thank you so much, Adele. Okay. Causes, as I said, of cerebral palsy. Well, we really don't know most of it, but we know that premature babies, that low birth weight, any sort of abnormality of the brain, leukoplasia of the brain, there's all different things. Occlusions, which means no blood flow, which is hypoxemia, apoxic episode to the brain. And the brain just doesn't like it and develops cerebral palsy. So we know that we have to look for this early in infancy. And with it being early in infancy, these children can get the proper occupational, physical, speech therapies as they're growing, and they could be more than you ever think. Now, Jonathan is an 8-year-old boy, nonverbal, who many years ago they wouldn't have even tried to teach. This child is doing numbers, shapes, colors, and he's a smart butt. I mean, he'll make you giggle. He is such an amazing kid. He's smarter, has more in there than we ever thought before. And it really warms my heart today that we're doing so much more with these children and giving them an opportunity to be something, to do something, instead of just sit in a chair and being fed and go to the bed and get a bath, right? That's what they used to do years ago. So we're going to evaluate these kids. Well, of course, the genetic metabolic testing absolutely will be done. We're going to take those x-rays of the brain, see what's happening to them. Now, as I said, Jonathan was spastic. And this is the one, when you think of cerebral palsy, this is which one you think about. The hypertonicity, right? That spasming, that tightness, poor posture. They can't sit up without being buckled in. And many of them cannot walk. And that's that difficulty maintaining balance. And if they walk, they're usually with splints and walkers in order to assist them. So that is spastic cerebral palsy. You're going to see them because they cannot use their muscles right. Delayed growth and delayed fine motors for sure. Their motor, it's not going to be in control, so it's abnormal. Of course, alterations at muscle tone, postures again. These children, the one thing we need to do for them is to give them ability to be able to move around, especially those children who have, being able to use an electric wheelchair or use a wheelchair. Or this boy here, he's on a trike. He's got his little braces on, splints on, and he's able to move around. And that really gives them, something. And it's exercise, isn't it? Right? We need them to be the best that they can be. We need them to be in social experiences, and they still need to have behavior needs to be appropriate. Just because they have cerebral palsy doesn't mean they're not supposed to behave the way that they should, and they will get punishments according to that. So, as I was talking about many times already, those foot braces, sometimes they do these orthopedic surgeries. If they're like completely spasm and it's not usable, they'll make a hand or a foot more usable. They also will use things like levodopa carbidopa. That's what you use in Parkinsonism. And that's the spasms, right? They use that in Jonathan. He's also had botulism injections. And remember, cerebral palsy, many of them have seizures too. And think of phenytoin, dilantin, and gingival hyperplasia, gingival. It's big red gums. We got to do really good dental care on them because they don't tend to, their saliva sits there. They don't tend to empty their mouths all the way. And even though Jonathan does eat by a G tube, his mouth still needed really good mouth care. And again, physical therapy, occupational therapy, speech therapy. And these kids are more than we ever thought they would be today. And many of these children should be mainstreamed into regular school if they're able to. Okay, because there is mild to quite severe. So, neural tube deficit. When you were in pharmacology, do you remember learning about folic acid? And they say if you didn't take it before you're pregnant, you have a chance for neural tube deficit. And you're like, well, what does that mean? Well, there it is, right here, spina bifida. This is a myelomeningocele. That's what you think about. When we look at all of these different ones here, the spina bifida, the meningocele, this is basically the meninges and spinal cord are pulled from the bottom and up and out and in the sac of the meninges there. So can you imagine at birth, what do we need to do? We need to protect that. That is the central nervous system. So a sterile dressing, and it needs to be moist. So normal saline, sterile normal saline, good dressing, keep and protect it from infection. These children are positioned on their bellies. They will not be placed supine. They cannot lay on that, okay? And they're usually fixed pretty well after birth, okay? Neural tube deficits, there's a couple other things that could be due. That neural tube, folic acid can help. Maternal obesity, diabetes, low B12, those are some things I think that can cause it. And we know that this has created the ripping of nerves or the interruption of the nerve and comes up into this big purple bulbous thing. And what's going to happen from basically belly button down? You're going to have some paralysis, sometimes complete. Sometimes they're able to move a little bit, but a lot of times they can't. Then they don't feel when they have to urinate. These children will get every whatever hour urine catheterizations to get rid of that urine. Also, can they control their bowel? And are they constipated? So these are things we really need to watch. Now, these children, because it affected the spinal column and meninges and the flow of fluid, will end up with a ventricular peritoneal shunt. And that basically keeps the fluid moving around and it doesn't block because of that big thing in the bottom, and there's going to be a lot of scar tissues in there. Now, let me tell you about Manuel Louis. Manuel Louis was a little newborn baby who looked just like this baby right here. And I just came on shift. I worked night shift, and I walked in and I saw a mother looking at this baby and crying, and there was no other nurse in there. So I can't leave a mother crying. I can't do that. So I walk up. I say, "What's wrong, Mom?" She goes, "Well, the doctor says there's nothing they can do, and that he may die." And I looked at him and I said, "Mom, you have a beautiful baby." I said, "He's going to have some issues, but they're going to put that thing back in." And I says, "I can see you're going to be the best mother. I can see so much caring in you." And then what I did, I sat her down on the chair, wrapped up this baby, pulled it up, and put her in her arms. And she just sat there and just started singing Calmate mi niño, which the Spanish people understand that. Calmate mi niño. 14 years later, I'm in the emergency room working, and this mother sees me through a glass window, and she gets one of the clerks to go get her. I come over, and she goes, "Betty Boop," because they called me Betty Boop. Was my name as a nurse, because you'll remember that. And she goes, "This is Manuel Louis." And I went, "What? He's this big already?" She pulls out a keychain about this big with a picture of me holding Manuel Louis in the newborn ICU 14 years ago. She said, "I've been looking for you for years. My baby's perfect. He goes to mainstream school, smart as a whip. It didn't affect his cognition. Smart. Just went to the 8th grade prom, had a date, and he just gave me the biggest hug." So when you see a little something like that and you say, "I don't know," just think about the future, because with proper care and management, these kids can be pretty well normal. Will he ever walk? No, but he does everything else. So we know it's folic acid. I don't have to tell you anymore. Floppy infant syndrome, the worst thing that could happen. These children usually die before 2 years old. They just don't have any muscle control at all, and they end up dying from respiratory distress. They're just flop. Basically, it says there, and they're also cognitively not there. Most popular, common, tested muscular dystrophy has these NCLEX, and you'll see them if you work pediatrics. It's called Duchenne muscular dystrophy. It is an X-linked inherited from mommy. It is males. It's ages 3 to 7, I believe the ages are. Yep, I'm right. And what happens is these kids are moving in the right direction. They get up, they start to walk, and they're doing okay. And all of a sudden, they start waddling. You'll see these hypertrophic calf muscles, and they start falling. And then they get diagnosed with using what we call an EMG. An EMG is this little machine. Sometimes it's little needles, sometimes it's patches, and they shoot an electric current in the nerve and they watch the arm move towards it. A child with Duchenne muscular dystrophy won't move immediately, it will be severely delayed. And that's how the diagnosis is made. Now, these children getting those tests, or anybody getting it, it's uncomfortable when you're done. I had it done many, many years ago, but it just really is like you've run a marathon because they're moving your muscles and seeing what's going on. And here again, what you see, that waddling gait, getting on the floor and getting up like an old lady, walking up their legs, that's Gower sign. That's how I get off the floor, or pulling on something, right? You walk up yourself. Lordosis, that big lumbar spine is curved back. And again, that hypertrophic calves, and they are mild to moderate cognitively delayed. And because of the muscle weakness, they're not moving. They're usually a little obese, but they're also not cognitively aware. These children, we keep them physical, speech, occupational therapy, monitoring diet, doing all of those things, embracing, etc. But usually these children end up by these children will end up in the teenage area. And now remember, it's muscle degeneration. Muscles will fail. What is a muscle? A heart. What is a muscle? A diaphragm. You stop breathing and the heart stops. And that is Duchenne muscular dystrophy. And, it is one of those things genetically that mothers and fathers really need to look at, because mother is the carrier. Now, you've had good Guillain-Barré yet in your med surg too? Okay, you will soon. Well, Guillain-Barré, it does happen in children. It's more often in adults, though. But what I've seen one, and it was actually a supervisor I worked with. This is a disease usually following some sort of upper respiratory viral something, because this is all viral. And what happens is it starts, the nerves in the lower extremities start to get weak, and it works its way up till it gets to your diaphragm, and then the phrenic nerve goes dead and you stop breathing. These patients require full ventilatory support, and they're awake and alert, and they can't move a finger. That's what happens to them. So you can imagine all of the nursing care involved. This is range of motion. This is full, incontinence, turning, positioning, keeping the lungs, et cetera, et cetera. What you see with these children first is they're falling down, waddling, and then all of a sudden they're incontinent and they start losing their urine, their bowels, and that's when we find it. Hard to diagnose, really is hard to diagnose. So all systematic, but the goal that we give is the intravenous immunoglobulins, IVIG. Let's just boost the immune system. Remember, it's viral. This is not antibiotics. Antibiotics is going to do nothing but give them diarrhea. So we're not doing that. So we also may do some steroids on them. Again, full ventilatory support on these things. And then anything that they need. Do they need heparin for blood flow? Do they need whatever? They'll be getting it. And then what happens? All of a sudden, you're going to hear the ventilator make a noise because now the machine is saying, oh, the patient's trying to breathe. So what does that tell you? The phrenic nerve is starting to come back. So it starts now going from up top to the bottom. So it goes descending. Now, the belly, you start, being able to control your urine, then you can move your legs and, walk, etc. Depending on how long you are out with this would be depending on how much therapy is needed to strengthen you when you are done. So it starts from the feet and it's ascending, going from feet up to the phrenic nerve. And then it goes away, it goes phrenic nerve down. So it does turn around, but it takes a long recovery. Tetanus, lockjaw. Everything here gets so tight and swollen. And lockjaw could be due to this colostrum tetani, it's called. Now, when you think of lockjaw, you think of stepping on the rusty nail, right? And needing a tetanus shot. Today we need to get tetanus shots every 10 years. At one time it was every 5 years, and then 3 years, and it was 5 years, and now it's 10 years. And, that's what they say it works well. But the problem with this lockjaw is think about your jaw tight, and then think about all the swelling that goes on to the neck. And then it gets all swollen in there. So now again, it's respiratory. So again, we'll be monitoring really close breathing, making sure, again, this child's ending up, it's going to be on a ventilator, respiratory support, and be given this tetanus vaccine and trying to keep these children alive, and they're very, very sick. You can see this. If they live beyond 4 days, they'll usually recover. That is that 4 days of a lot of work. So what do we do when we get this cut that we stepped on a rusting nail? Well, they should be getting one of those tetanus toxoid or antitoxin, a booster. Sometimes, like animal bites, they'll put it around the bite to be sure. I've seen raccoon bites. I'm like, who knows a raccoon in Florida? Well, apparently there is. Um, if it's dirty, wash it, soap and water. Just clean it. Put an antibiotic on it and a Band-Aid. That's all they need to do with it to keep that wound clean. And remember, frostbite also is a problem. And again, you need to be immunized for that. So how do we manage it? Like I said, respiratory support, you're monitoring fluid electrolytes, IVIG again, that tetanus IVIG will be given, cleaning the wound even after, they have, the disease. Of course, we want that wound to be clean. And because of that extra spasming, these children will be paralyzed, which means they are chemically induced to have her muscles relax. Because if you can imagine, go ahead, put your jaw tight. Keep it there for 30 seconds. It hurts. Can you imagine? 4 days. So it relieves that pressure. And they also put them on great sedation. So they really don't remember this, but it is severe. Now, how many of you have ever given a little bit of honey to your infant because they were constipated? There is some cultures that believe it. And It could be honey or that Caro syrup, that light or dark corn syrup. And they give them a little bit, and it does help with constipation. But it can cause botulism, which is a really bad condition, because how long was that honey in that jar before you got it? Who cleaned the jar? What's the regulatory status? How old really is that honey? Et cetera, et cetera. You can see all of the bottling and handling of it. There's too many ifs and not understood. So with this one, what they start to see again is that weakness, vomiting, and again, respiratory paralysis. So again, it's the IV botulism immunoglobulin, again, respiratory support, and always with any condition where they're paralyzed, sedated, they're ill, always nutrition, 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 hyperal, lipids, or even NG or ND tubes into the duodenum. They put them a lot today, where they're getting some formula or high calorie food. Always good nutrition. And you heard me talk about my little C5-6 fracture kid, and it's a spinal cord injury. And knowing that we need to be very, very careful with these and the handling of it. And our job is number one, keeping that neck, that spine, that back straight. And you, as a nurse, even the little shy, timid ones, because I used to be one of those, not anymore, but I was. No, move it on my count. We're going to move on 3. And then make sure everybody's hands are where you want them. And you can save paralysis on these children. So again, proper immobilization. And we know neck injuries, monitoring their respiratory status, absolutely monitoring paralysis, all of that goes with it, but it starts with that proper immobilization. So do you remember which progressive infantile spinal muscular dystrophy is the most common paralytic form? A floppy infant.
E.
It's C. So there was our stuff for today. So now we're just going to do our cahoots. And when we're done with our cahoots, we're going to have anything you want me to do. There's going to be a little bit of time left. If you want me to go, we've done it before in my class, dosage calc, if you want to do that. Or, if you have questions regarding HESI that I had some earlier, we'll have that. And then when we're done, then we'll be out of here, okay? So who wants to win today? Jonathan, you need to win this one. Well, Casey, we can do 2 things. We could take a break or we'll be here longer. Now, if you need to get up, go get something, do it. If I never tell you you have to sit here staring at me the whole time. If there's something you need to get up quickly and do and come back, please do it. If you need to eat, you need to go to the ladies' room, you need to check a kid.
I just have to give my son his medicine. He has a cold.
Well, there you are. Go for it. Not a problem. Now, when you have another class with you, they don't know you as much as you all know me. So, and I know you all always want to get out when you can, because it's a long day for most of you. So let's just put up this and everybody can start to sign in. Omi, how was your trip?
Good. Thank you.
Okay. So for my group, most of you have turned in your projects. Make sure that if you haven't, it must be in by Sunday. And unless there are something that I know about, there'll be a minus 10% deduction. I have scored all of those projects already for those who turned it in. And I'm giving you one chance to look at it and make a correction according to what I said. So that's up to you. In fact, I had already one that's already returned it back and I already rescored it. So I'm trying to keep up to date on those for you. Who else do we have today? All right, anybody else want to join? You go to kahoot.it, you put in the PIN number, and you will connect to my game. That's how it's done. It's very easy. So Casey, go to www.kahoot.it, put in that PIN number, and you can join us too. And you have to do it on your phone. And then your screen, you can push the button. Click the button, okay? And we're going to go ahead and get started, guys. Here we go. Musculoskeletal and neuromuscular dysfunction, week 9. Wow. What is the priority for a nurse to assess following a cast application? It is a fractured leg, fractured, tibia, fractured ulna. What do you need to look at? Cast been put on. Pediatric hospitals have beautiful colored casts. Go to an adult hospital, they're going to have white ones. The kids like the colors. Makes it less upsetting to them. It gives them a distraction. It's everything. Pulses, pain, movement, sensation, right? These are all these concepts that you need to know about looking and assessing a cast. What should the nurse monitor after a soft tissue injury? So you got a big old ecchymotic area. What do you need to look at? What are you concerned about? It's just a bruise, right? So remember, that bruise could swell, could occlude blood and nerves. So checking the neurovascular signs, most important thing. A fracture that penetrates the skin is called what? It's called compound or open fracture. Remember, that's going to require long-term antibiotics. What is the priority nursing care of a child with a compound fracture? And if you notice, a finger, a toe can be a compound fracture. It doesn't have to be an arm or a leg. And IV antibiotics, you need to fight the infection. You have opened that bone to the air and all of the contaminants of around that air. And they could get an infection. You could lose the arm, the leg, and you can cause overwhelming sepsis. This kid could die from it, actually. What is priority nursing care for a child who fell off a second floor balcony? Now, I've seen this. I've seen them come down and really not be that bad. And then, of course, I've seen the absolute opposite where they haven't done well. Again, you don't know in that neck, that back, what's going on. Always keep them immobilized till it's ruled out. You know, they come into the trauma room. One of the first things they're going to do, besides just a quick overall inspection, is they're going to do an x-ray of the back. They want to see immediately if there's something going on. Principles of managing soft tissue injury includes get a sprain like I do. What do you have to do? And that's rice. Rest, ice, compression, elevate. Yes. An epiphyseal plate fractures in children may what? It's all about bone growth. So absolutely, it's that. Again, that's an open reduction, internal fixation that requires really meticulous care. What findings for a patient in skeletal traction indicates peripheral neurovascular impairment? So, peripheral neurovascular impairment, neurovascular checks is all about blood flow, absent peripheral pulse, excellent, prolonged capillary refill. Those would be things that you would see. Paresthesia, right? A multi. What should the nurse care for the skeletal traction for a child with a fractured femur? So, how should they care for them? So, you've got traction, which is that it's not skeletal, it's actually skin traction. And they'll put it on to pull out that femur, right? So you've got it to a weight, it hangs over the bed. And those weights are depending on the size of the child. So that weight, number one, every shift, you must document how much weight is there. You also, that weight must be free hanging and never ever should be taken off for bath, for potty, for anything, because what it will do is it'll dislodge that femur and then it's going to cause those muscles to spasm and then you go back to square one in pain. So always keep them free hanging. Very good, guys. When caring for a 9-year-old in Buck's traction, what action by the nurse is correct? Again, this is all about circulation and it's capillary refills that we check on that. You know, absolutely. We're not going to let them sit on the bed. They're not going to put the weights anywhere. They're not going to put the bed up and down. Leave it alone and keep that traction hanging freely. A multi. Which assessment indicates an infant has developmental dysplasia of the hip? So we're going to see a positive ortolani. I'm going to hear those clickings going on there. And I'm going to see those skin folds, the gluteal folds. They're going to be irregular. A moral reflex, the other name is called startle. That's when they're very young, right? You hit them or make a loud noise and it comes with their hands up and they're startled. And Babinski is just like adults doing of the sole of the foot near toes splay. What position do you put the legs of an infant with hip dysplasia? It's called abduction, okay? Remember that. It's not ad, it's an abduction. And it brings the legs up, so it tries to put those hip sockets back where they need to go. What statement by parents indicate more teaching regarding their 2-year-old infant with club foot? I mean, those club feet in that picture is quite severe, isn't it? So remember, I told you club feet you're born with, it's congenital. So remember that first neonatal period, 28 days, they heal quickly. So you don't want them to heal in this really weird position. So start it as soon as you can. They need to be coming every week, not every month. Okay. And so that would be your answer, which is they need more teaching. Also, again, remember they're going to be needing follow-up until they're older, followed by orthopedics to make sure that their feet are keeping in the proper alignment. So in 1 month, that's going to be already healed, and there's no way to bend it anymore really easily. And they're going to end up with surgery on that kid because we did it too long. A multi. Osteogenesis imperfecta. Remember, this is the one where we're trying to keep these children in some sort of position that's functional. They can get out of bed and sit in a chair or get in a wheelchair and be mobile. Because most of these kids are alert. It's called long bones are crooked. Yes, they are. Brittle bones is the big thing. And you're not going to be doing physical therapy on this child. You'll break the bones easily. Actually, you are going to see some of these children, it's not diagnosed immediately, and they're brought in for child abuse because they see all of these broken bones on this child. Can you imagine? And then, I didn't do anything, but they're arresting me for child abuse. And then they find out that it is osteogenesis imperfecta. It has happened. What is the pathologic cause of leg calf Perth disease? It's the head of the femur. It's called an ischemic aseptic necrosis of the femoral head. That means there's no blood flow. Somehow something happens. And there's no infection. It just the head of the femur dies. Kyphosis, which one is that? You have kyphosis, you have scoliosis, have lordosis, and kyphosis is the upper back. It's called humpback. Lordosis is described as what? So lordosis is the lumbar spine. Great. Scoliosis. Make sure I cover all of them, right? And remember, scoliosis, S-shaped curve. Very good. S-shaped curve. And remember, if it's over 40, 45, depending on the book you read, they're going to need to do surgery on it. If not, they're going to do just physical therapy. So adolescents with scoliosis have up to a 45% curvature of the spine would need to what? So you're up to that. You're up to 45. As I said, 40, 45. What do you do? And then over 45, how would you treat it? So up to 45, you're going to wear a brace 23 hours a day. Remember, there should be a t-shirt or something underneath it to prevent rubbing and skin breakdown, and physical therapy. They need good strengthening of their muscles, and that will help. After that, it's surgery. What is osteomyelitis? And it's an infection of the bone. And remember, it does require the antibiotics, good skin care. Goals for juvenile idiopathic arthritis include so we just don't want the body to attack the joints. We want them to be at rest as we can. So we want those joints to be as least pain as possible and decrease the swelling there. That is the goal. A multi. What might you anticipate for a child diagnosed with JIA? So JIA, you worry about the joints, of course, the walking because it's painful, especially in the morning. That uveitis, facial rash is your lupus. A multi. What can help a child with lupus erythematosus prevent exacerbations? So one of the things with lupus is sunscreen, or exposure to sunlight. I mean, stress and all of those things, decreasing it, that helps. But, living in where I do was one of the big things. And of course, prophylactics before any sort of procedures, like a dental extraction. What organs can lupus affect? Then I'll ask you, is there a limit to what organ? And remember, skin is considered an organ or integumentary, right? So everything, all of the above, any organ it can affect. What is cerebral palsy? Cerebral palsy is all about the nerves and the muscles misfire. They don't function, they don't work, and it's all sorts of problem with body movement and coordination, and they can't have their body do what they want to do. It just mostly it's spasm and spastic. A myelomeningocele. What is it? That big glob of whatever. What is that on that infant's back? Remember, they're born with it. It's congenital. It's the spinal cord and the meninges. Remember, when it rips up the bottom to come out, remember all of those deficits, those neurological deficits that are in the lower extremities. Infants with myelomeningocele demonstrate what? You know, because of that, nerves have been ripped as it came out. There's going to be, deficits in motor and sensory. They may not be able to move at all. They may not be able to feel at all, or they might have a little bit, okay? But it's always there. There's movement and feeling is debatable on a myelomeningocele. How much of that nerve was ripped to come out and make that myelomeningocele, that big blob of meninges and spinal cord. Myelomeningocele have decreased motor sensations of the lower extremities. The nurse should monitor closely what? It's all about urinary tract. They don't urinate. Many of them don't feel it, and that is your biggest things to watch after. Now, are we going to look for the other stuff, making sure that they have physical therapy and we're working the muscles and the skin, etc.? Yes, but one of the things that we really need to watch closely is if they're urinating, because we might have to do a straight calf every 4 hours or so. A key feature of Duchenne muscular dystrophy is, what do you know about Duchenne muscular dystrophy? X-rated, the X-rated, the X mother's X chromosome is the carrier, males ages 3 to 7, and what we see is this progressive muscle wasting. So they're starting to go forward, lifting their head up, walking, doing all the developmental things they should, and all of a sudden, might be a little slower, but they go backwards, and they start losing muscle strength. What is one of the procedures that a child with possible Duchenne may need to diagnose this condition? And that's that EMG, or electromyography. So it's electric to the muscleography. If you look at what the name means, they take a little electrical impulse, put it, and they watch the muscle contract. And usually it'll be slow with Duchenne's. How is Duchenne muscular dystrophy inherited? Now, remember, this is not something that you treat and it goes away. This is lifelong. Nothing you can do, just do the physical and occupational and speech therapy and keep their muscles moving. And it is mom's X-linked recessive gene. In caring for patient with Guillain-Barré, the priority concern is what? They were usually caused by some upper respiratory, it's viral, and the nerves just stop working. And it goes from the feet and it goes up, and all of a sudden the phrenic nerve is gone, and now we must maintain an airway. These children, adults, will be on a minimum of an oxygen sensor, right? For a patient suffering with Guillain-Barré, they would complain of weakness that was what? So when they get the disease, what would they complain of? And it's what we call ascending. It starts from the feet and it works up to the chest, right? Ascending. And when it all of a sudden it's, going to turn around and go away, it goes descending from the chest and it works down to the feet. Very important concept of that Guillain-Barré. A multi. Treatment for Guillain-Barré include what? So as I said, Guillain-Barré is viral, has nothing to do with any bacteria, so it's not antibiotics. IVIG respiratory support, maybe they're on heparin, but that is not necessarily the package for treatment for this. Maybe corticosteroids, maybe steroids with this. So IVIG, steroids, respiratory support. What type of cerebral palsy has hypertonicity and poor fine motor skills? This is Jonathan. I'm going to have to go see that kid. And it's called spastic. Spastic. And, when you think of cerebral palsy, actually, this is what you think of. You think of that child who's tight in the movement and they can't move well. Remember, there's all different levels of cerebral palsy. Hypertonicity, those poor fine motor, that's usually the child who's in the wheelchair. But remember, there are kids with cerebral palsy that are up and walking and moving and can live more of a, quote, normal life, okay? But spastic is what we usually think of. What priority action should a nurse take to a patient with a suspected spinal cord injury? And that's making sure that spine doesn't move and create more injury and more damage. Very good. I think that point was well made. You should get a tetanus shot every how many years? If you've had no stepping on toes or cuts or animal bites. And yes, it's 10 years. And they're doing tetanus with the DT also, diphtheria with it. So they're redoing that one. That was something they knew that they added, about 10 years ago. Which is a symptom of tetanus? Oh, I stepped on a rusty nail. Tetanus. Very, very serious condition, requires some really good wound care. And it can create that lockjaw. And remember that lockjaw, the spasm, it creates swelling in the neck, and then it's all about respiratory. These children are sick, and we treat them with that IV tetanus toxoid. And last question. The most common causes of spinal cord injuries are what in children? And it's motor vehicle. That's always number one. That's the biggest thing for accidents in all age children. Driving, sports, anything has to do spinal cord injury. Kids, they like to jump off crazy things, down trees. I've done it. Amy, number 3. Good job, Amy. Number 2, J. Number 1, let me guess. Yeti. Number 4, Queen B, or is that Queen Betty? And DK. Well, good job, guys. So that was a quicker of me, for me, one of my quicker ones. So there is a little bit of time if you all want to do anything. If not, I'm okay. It's up to you. What do you want? So I am here for you. If you need anything about anything, I will answer that.